Hello everyone, welcome to the final part of the chapter Neoplasia. Here we are going to discuss a very important question or a very important concept, that is chemical carcinogenesis. It's very easy. Carcinogenesis is a multi-step process. There are some sequences. Carcinogen, suppose for example, I or you, if either of us are being exposed to a carcinogen, we don't develop malignancy or any such things in a very short period of time. It will take long duration. Am I right? Yes. That means there is some mechanism which is responsible for the malignant neoplasm to develop after being exposed to a carcinogen. Fine? Yes. So, okay. What are those? Number one, initiation, then promotion. These are the two steps, initiation and promotion. Okay, yes, initiation and promotion. Please go through this flowchart. Whenever there is a carcinogen, it will be metabolically activated, which produces some electrophilic intermediates, bind to the DNA, and which leads to an adduct formation. What do you mean by adduct? Adduct is nothing else but the DNA along with the carcinogen. Simple. Okay? Yes. Which will cause this permanent DNA lesion, cell proliferation or altered differentiation, pre-neoplastic clone, then finally malignant neoplasm. Okay? As a result of what? Proliferation and the additional mutations. Fine? Yes. Okay. Sometimes this carcinogen undergo detoxification and they may be excreted through kidney, and this abnormal DNA, when it formed, it may leads to cell death. When both these doesn't happen, malignant neoplasm ensues. Fine? Yes. Okay. So initiation and promotion. Fine. Then we comes into, so this flowchart is very important. So the initiation results from exposure of cells to a sufficient dose of a carcinogenic agent, and initiated cell is altered, making it potentially capable of giving rise to tumor. That is the first step. Then the initiation will cause some permanent damage, or we call it as mutation, which is rapid and irreversible and has memory. The tumors are produced even if the application of the promoting agent is delayed for several months after a single application of the initiator. Okay, that is why there are some carcinogenic agents. Am I right? Yes. Even though we are exposed to that agent, even for these are damaged cells which have a damaged DNA, which has that adduct, has memory, and that is responsible for the malignant neoplasm. Okay, formation. Yes. Okay. Then we have direct acting carcinogens and indirect acting carcinogens. What do you mean by direct acting? That means in order to become carcinogenic, they do not require any metabolic conversion. The best examples of them are cancer chemotherapy drugs or alkylating agents. The alkylating agents which we are using for cancer chemotherapy, they are the most culprit because they are going to cause some other cancers. Fine? Yes. Okay. Then coming into indirect acting carcinogens. So see, let us go through the examples of direct acting carcinogens. Fine? Yes. That means the alkylating agents and the acylating agents. Out of that, the most important are dimethyl sulfate, propiolactone, diepoxybutane, anti-cancer drugs like cyclophosphamide, chlorambucil, nitrosoureas, and others. Acylating agent, we have 1-acetyl imidazole and dimethyl carbamyl chloride. At the same time, indirect acting carcinogen, they require some metabolic conversion so that the inactive carcinogen should be converted into direct carcinogen. Okay, and this includes almost all of our examples. There is a polycyclic hydrocarbons which are present in the fossil fuels, pyrene, benzopyrene, okay, tobacco present in the cigarettes, all those things. The polycyclic hydrocarbons, they are also present in smoked meat. Fine? Yes. Then all this, what they are going to cause? Finally, they are going to cause us adduct formation by DNA damage. Fine? Yes. Then we have another class, that is what we call it as aromatic amines and azodies, aniline. Okay, aniline, all those causes bladder and scrotal cancer. Fine? Yes. Okay. How this conversion occurs, you know already, cytochrome P450, yeah, okay, dependent monooxygenase, fine, yes. So that is the main enzyme which helps in conversion of this inactive compound into active compound. At the same time, for some of the compounds, it will causes detoxification, so those carcinogens will be eliminated through kidney, fine. See, these are the carcinogen that require metabolic activation: benzopyrene, okay, then naphthylamine, okay, aflatoxin causes liver cancer, griseofulvin, then nitrosamine, vinyl chloride causing hepatic angiosarcoma, then polychlorinated biphenyls. Please go through all these examples. They will definitely ask this. Okay, chemical carcinogenesis is a very frequently asked long question for your prof exam. Okay, what are the molecular targets of chemical carcinogens? Chemical carcinogens, they should need some mediators. Like, what are those mediators? Okay, the number one, remember, DNA itself is highly susceptible to mutations. Am I right? Yes. So the most important tumor suppressor, okay, that we encounter is nothing else but our two important thing. One is our RAS and another one is TP53. Okay, yes. And even our aflatoxin, no, B1, that from the aspergillus, that is having very high incidence of causing hepatocellular carcinoma. Okay, yes. Then coming into the promotion of chemical carcinogens, what are promoters? They are not mutagenic, but they will stimulate cell proliferation. Okay, in the classical experimental system, some of the best examples of the promoters are, you should know this: 4-bol esters, hormones, phenols, and some other drugs. Fine, they don't directly cause mutation, but at the same time they will stimulate cellular proliferation. Just completion sake. Fine. Okay. Then now let us see about the radiation carcinogenesis. Out of that, in that we have ultraviolet rays. Ultraviolet rays are most common, having increased incidence of squamous cell carcinoma, basal cell carcinoma, and melanoma of the skin. And remember, this ultraviolet, B is the most important culprit responsible for the induction of the cutaneous cancer. Okay, and whereas ultraviolet C, it is not considered significant because it will be filtered out by the Earth's ozone layer. And what is the reason for this carcinogenity of the ultraviolet B rays? It is because of the formation of the thymidine dimers, also called as the pyrimidine dimers. Okay, yes. Okay, so because of the cross-linking of the pyrimidine bases, okay, that is the thymidine bases, what will happen? It will distort the DNA helix and it will prevent the proper pairing of the dimer with the bases in the opposite DNA strand. So normally these are repaired by the nucleotide excision repair pathway. At the same time, when there is a defect in the nucleotide excision repair pathway, as in case of xeroderma pigmentosum, there will be increased risk of skin cancer following ultraviolet B exposure. Ionizing radiations, we have the CT scan, which has a very high risk of getting causing leukemia. Then microbial carcinogenesis, oncogenic RNA virus is very, very important. Out of that, H, that is human T cell leukemia virus type 1. Okay, what actually it is do? It has the high affinity for CD4 T cells. Okay, TD4 T cells. Yes, and this, remember, this HTLV1 genome has some polymerizes enzyme genes called as GAG, POL, and ENB. These three are the same genes that we encounter in HIV also. And out of that, TAX, it is essential for viral replication. What is the name of the protein, children? The name of the protein is called as TAX. It is this TAX protein which is going to causes abnormal cellular proliferation. Then it uses two pathways. One is the increased pro-growth signaling pathway via PA3K AKT signaling pathway via the TAX gene, and it also causes increased genomic stability. Instability. Fine. Then oncogenic DNA virus, we have hepatitis B, Epstein-Barr, Kaposi sarcoma. Okay, yes. Yes. Then our HTLV1 is an RNA virus. Then human papilloma virus, here two important points. It has two protein children. One is E6 and E7. Okay, remember the P53 binds with E6 and E7 binds with the retinoblastoma. So when it is going to inhibit P53 and inhibit retinoblastoma, it will cause immortalization, increased cellular proliferation, and genomic stability. As I have already told you, see, this is E6. E6 is P53 and E7 is retinoblastoma. Fine. So what are the clinical conditions it is going to cause? We have two types. One is called as low risk HPV or low risk are 1, 2, 4, and 7, which causes benign squamous papilloma, also called as warts. Whereas high risk are type 16 and 18, that is responsible for causing squamous cell carcinoma of the cervix, anogenital region, head and neck. Okay, particularly in the tonsillar mucosa. All these are sexually transmitted. Okay, yes. Out of that, the high risk includes what we call it as the Yes, so we have high risk and low risk. I told you, low risk are mainly HPV 6 and 11, whereas 16, 18, all these are high risk HPVs. Fine. Then Epstein-Barr virus. Again, Epstein-Barr virus, it is going to cause Burkitt's lymphoma, Hodgkin's lymphoma, then nasopharyngeal carcinoma, and in, of course, some forms of gastric carcinoma. Out of that, the most important are what we call it as our Burkitt's lymphoma, nasopharyngeal carcinoma, and some other variants of Hodgkin's lymphoma. So here we have an EBV gene, that is what we call as LMP1, that is latent membrane protein 1. Okay, it will activate the CD40 receptors, and it will also activate the nuclear factor kappa B and the JAK-STAT signaling pathway that is responsible for abnormal B cell proliferation. Fine, yes, and it also prevent apoptosis by activating BCL2. Okay, I told you, BCL2, MCL1, all these are anti-apoptotic proteins. These anti-apoptotic proteins are inhibited. So what will happen? There will be abnormal formation of neoplastic cells. Okay, yes, 814 translocation, remembering Burkitt's lymphoma. c-MYC, okay, 814 translocation. Once that is done, then hepatitis B and C virus. Hepatitis B and C virus, okay, that's not that much. Just remember, hepatitis C virus has been found to cause hepatocellular carcinoma in the last 4 decades. Then Helicobacter pylori, here only one MCQ question you will be getting. We have two genes children. What is that? One is called as CAG-A gene. Okay, what is the name of the gene called? CAG-A gene. It is the CAG-A gene that is responsible for causing gastric adenocarcinoma and gastric maltoma. Gastric maltomas and gastric adenocarcinomas are caused by this CAG-A gene. That is very important MCQ question. Coming into the clinical aspects of neoplasia. Okay, the clinical aspects of neoplasia. What is the most important point? What I have to remember is cancer cachexia. Remember, cancer cachexia. Individuals with cancer, they suffer progressive loss of body fat and lean body. Am I right? And there will be profound weakness of the body, anorexia, anemia. All this is what we call as cancer cachexia. Okay, and the most important culprit or the most important mediator that is responsible for cancer cachexia is TNF alpha. Okay, TNF alpha, very very important point. Okay, yes. And another most important is paraneoplastic syndrome. That means the cancer-bearing individuals will develop some signs and symptoms that cannot readily be explained by the anatomic distribution of the tumor. For example, a patient will have breast cancer. Then why he should develop hypercalcemia? There is no relation. We can't explain. So that is all those conditions we call it as paraneoplastic syndromes. We have a lot of paraneoplastic syndrome. Out of that, endocrinopathies are frequently encountered. Okay, and remember they are not of any endocrine origin, but they occur as a result of an ectopic hormone production. The most common endocrinopathy that we encounter is what we call it as the Cushing syndrome. Okay, it is because of the excessive production of corticotropin or pro-opiomelanocortin. Fine, yes. Hypercalcemia, it is the most common paraneoplastic syndrome is hypercalcemia. What is the most common endocrinopathy? Cushing syndrome. Then the two important reasons for cancer-associated hypercalcemia are, number one is what we call it as osteolysis induced by cancer in bone, like in multiple myeloma, or any metastasis to the bone from any primary lesion, or because of the second theory is that production of some calcemic humoral substance. Out of that, the most important is parathyroid hormone related peptide. Okay, yes, that is one of the reasons for hypercalcemia in associated with cancers. Fine. And another most important thing is, remember, see PTHRP, hypercalcemia means squamous cell carcinoma. Then acanthosis nigricans, there will be thickened hyperkeratotic skin with a velvety appearance. This is most commonly associated with gastric cancer, lung cancer, uterine cancer, carcinoma. Fine. Then hypertrophic osteoarthropathy, most commonly encountered with the lung cancer. This is characterized by new bone formation, periosteal new bone formation at the distal end of the long bones, metacarpal, phalanges. You can get new bone formation. Okay, and there will be arthritis and clubbing of the digits. Then another most important thing is called as migratory thrombophlebitis, okay, which is most commonly associated with carcinoma of the pancreas. Then DIC, disseminated intravascular coagulation, most commonly associated with acute promyelocytic leukemia and prostatic adenocarcinoma. All these are straight away direct MCQs. No way you can miss these questions. Fine, let us see this. See, Cushing syndrome. Cushing syndrome is most commonly associated with small cell carcinoma of the lung and pancreatic cancer. Then SIADH, syndrome of inappropriate ADH secretion. Again, it is small cell carcinoma of the lung. Hypercalcemia, most commonly associated with squamous carcinoma of the lung. It is also associated. What is the most common paraneoplastic syndrome present in breast cancer? Again, answer is hypercalcemia. The problem is parathyroid hormone related peptide. Okay. Then polycythemia, very very important, is renal carcinoma. This has been asked 2 years back in Central Institute exam. Polycythemia vera is one of the paraneoplastic syndrome associated with renal cell carcinoma because of increased erythropoietin production. Then myasthenia gravis in bronchogenic carcinoma. Again, this has been a question. Acanthosis nigricans, gastric cancer, lung cancer, uterine carcinoma. Hypertrophic osteoarthropathy, bronchogenic carcinoma. Okay, myasthenia gravis, hypertrophic osteoarthropathy, clubbing of the fingers, all this in bronchogenic carcinoma. Trossio phenomenon, mainly pancreatic carcinoma. DIC in acute promyelocytic leukemia. We call it as PML rara. PML rara, we will see in hematology. PML rara fusion gene is present in acute promyelocytic leukemia. That is also called as AMLM3. Then nephrotic syndrome, various kinds, that's not specific. Red cell aplasia is in case of thymic neoplasms. Fine, yes. Just go through this. Once that is covered, you should know what is grading and what is staging. See, grading is the degree of differentiation. Okay, actually grading is nothing else but a histological finding. Staging is clinical based on the tumor node and metastasis, and all of the tumors we use a staging. That is what we call as TNM staging. T stands for primary tumor, N stands for regional lymph node, and M stands for metastasis. Okay, then we have clinical and cytological methods: biopsy, fine needle aspiration. Okay, yes. Okay, then IHC, then flow cytometry, and IHC, that is fish. Okay, fish and all is there. HER2 and all, we can amplification can be detected by fluorescent in situ hybridization. Then PCR, DNA microarrays, PCR. Okay, DNA microarrays, all those are there. And finally, we have something called as tumor markers. What are tumor markers? Okay, they are the biochemical assays for tumor associated enzymes. Remember, these are not used for definitive diagnosis of cancer. Single important point. They will give all of the following are true about tumor markers, except only one option you have to, your eyes should always search for. They will give, okay, tumor markers are used for definitive diagnosis of cancer. Wrong. Tumor markers are never used for definitive diagnosis of cancer, because in many other chronic inflammatory conditions also tumor markers will be raised. See, HCG, human chorionic gonadotropin in trophoblastic tumors and non-seminomatous testicular tumors. Calcitonin in medullary carcinoma of thyroid. Catecholamine and metabolites in pheochromocytoma. Alpha fetoprotein in liver cell cancer. Carcinoembryonic antigen. See, alpha fetoprotein and carcinoembryonic antigen are both, they are called as oncofetal antigens. Okay, liver cell cancer and carcinoma of colon, we can see CEA. Prostate acid phosphatase in PCP. Neuron specific annulase in small cell carcinoma. Not only in small cell cancer, all the neuroendocrine tumors will get neuron specific annulase. Immunoglobulin multiple myeloma. Prostate specific antigen again in prostate cancer. Here comes a very important question. You should remember these three things. Okay, every year they will ask MCQ. CA125 is in ovarian cancer. 99, CA99 is in colon pancreatic cancer. CA153 is in case of breast cancer. Then TP53, APC, RAS. When it is RAS in and APC together, definitely it is colon cancer. Only RAS, it is pancreatic cancer. Okay, and when the RAS is present in stool, it is pancreatic cancer. When the RAS is present in sputum, it is lung cancer. And if the TP53 is only present in urine, it is bladder cancer. Again, I think in JIPMER 2 years back they have asked this one question from this 4. Okay, yes, please go through that. So with this, we have finished it. See, this is the PSA, prostate specific antigen. No, it is not specific of prostatic cancer, because even in benign prostatic hyperplasia, it is increased. And remember, carcinoembryogenic antigen, it is seen in carcinoma of the colon, pancreas, stomach, and all, breast, even breast. Alpha fetoprotein in hepatocellular carcinoma, then teratocarcinoma, embryonic cell carcinomas, all those things. Then CA125 for ovarian tumor, immunoglobulin for multiple myeloma, HCG for testicular tumors. Fine. So with this, we have finished our final part of neoplasia. Thank you.